I'd love to introduce to you Jessie Rice, who is general psychiatry trained, child psychiatry trained, and now is about to be integrative psychiatry trained. Fiona, who gave an outstanding grand rounds last month to our department on the role of thyroid and integrative approaches to mental health. And so we have asked her to share some of what she knows, and then we will open it up to discussion and next steps. Hi, Jessie, it's all yours.
Okay, hi. So I don't have slides, so I apologize to the visual learners. I had a technical issue with the computer that prevented me from being able to put up slides too, but I'm happy to share the slides as well. So yeah, just to quickly review, thyroid function is really important in mental health, especially as we get into like the late teens and adult psychiatry. It's less of a deal in child psychiatry, and yet there are still recommendations for testing in certain situations, but focusing just on more probably adult and late teen population. So the psychiatry has a history of sort of getting involved in the thyroid function. Not only do we have studies that show that people who are in a depressive state do have altered thyroid levels, whether it's T4, T3, response to thyroid releasing hormone, TSH levels can be different. So we know that depression affects the thyroid axis, the HPT axis. And but beyond that, psychiatry also has a history of supplementing or augmenting with T3 to either accelerate treatment with antidepressants or to augment treatment-resistant depressive symptoms typically. And it's usually done in SSRIs or TCAs. It was never a part of my training. Being, I guess, fresh out of training, it's just sort of fallen by the wayside, at least places where I've been. Although the STAR-D trial did show that supplementing with T3 was just as effective as supplementing with lithium, supplementing not as buying a supplement, but like using it as an adjunctive treatment to an SSRI in treatment-resistant depressive symptoms. And it was actually better tolerated than lithium. But anyways, so there's a history of psychiatrists being interested in the thyroid, but how integrative fits in is because the thyroid is very dependent on a lot of nutrients and environmental factors to function optimally. One of the biggest things is that the thyroid actually has a really rich lymphatic supply, and that it's very vulnerable to having like environmental toxins. And we're seeing a large increase in the number of people taking thyroid medication. We know now that levothyroxine or Synthroid is the second most commonly prescribed medication in the United States, and it's been like that for a bit now. And just to quickly review, so the thyroid gland is stimulated by TSH from the pituitary to release mostly T4. The thyroid gland makes very little of the body's T3, which is the active thyroid hormone. Most of that is converted in peripheral sites and from T4. And so it's T4 that's the longer, more stable circulating hormone. And that's why endocrinologists go for this T4 prescription rather than T3, just because it's more stable and easier to monitor in that way. But you know, in primary hypothyroidism, people have an elevated TSH and a decreased, like lab decreased free T4 levels. Most of those people have Hashimoto's, which is the presence of positive thyroid peroxidase antibodies. Like 95% of people with true hypothyroidism will have Hashimoto's. And then there are a growing number of people who have subclinical hypothyroidism, and that is still controversial about how it is defined, but it's basically an elevated TSH, whatever you set your TSH cutoff to be, can be debated, and then a normal free T4. And about 50% of those people will have TPO antibodies as well. So just thinking about the role of autoimmunity and inflammation, even in subclinical hypothyroidism, it's important to think about. About 3 to 15% of the US population has subclinical hypothyroidism, and about 3 to 4% of people have primary Hashimoto's hypothyroidism. I'm not going to talk about hyperthyroidism and Graves' disease for this because it's much less common. And so T3 is thought to increase BDNF in the brain and improve transcription of serotonin receptors in the brain, and it might increase from second messenger systems in the frontal cortex. There's a lot of roles for T3 in the brain, and since the brain is a very metabolically active site, the conversion of T4 to T3 is really important to make sure that it's happening optimally for our patients. And we know that lower thyroid function is linked to depressive symptoms. So just kind of going by the category. So Hashimoto's is linked to depressive symptoms. There was a study done that showed an odds ratio of 3.31 for depressive symptoms, and even for anxiety of an odds ratio of 2.32. That study was done, published in JAMA in 2018. There have been other studies that have replicated similar enough findings. For people with subclinical hypothyroidism, we also know that there is an increased risk of depressive symptoms. The odds ratio is about 1.78 according to one meta-analysis that was done in 2019. And then for people with postpartum thyroid disorders, so we know that women going into pregnancy or during pregnancy who have positive TPO, thyroid peroxidase antibodies, have a much higher risk of mood disorder and perinatal depression. And in fact, some authors, like the British Journal of Psychiatry in 2018, recommended that all women with postpartum or perinatal mental health disorders, psychiatric disorders, be screened for thyroid dysfunction, at least TSH. So we know that we're not going to go in depth into the pathophysiology about it. Some of it has been pretty well shown, and some of it is still sort of hypothetical at this point. But the idea is that psychiatrists do need to care about thyroid because there are quite a number of thyroid patients with hypothyroidism, treated patients who come to see me and probably many others who have depressive symptoms, but their TSH is within the normal level, and so is their free T4, and yet they continue to have symptoms. And this is where integrative can be really useful, because, so just talking about the general recommendations for thyroid screening. Okay, so in psychiatry, there are no routine universal recommendations for thyroid screening. It's standard of care for somebody that is having a psychotic episode, first break, that sort of thing, possibly even for severe treatment-resistant depression, to screen for thyroid dysfunction, but it is not routinely recommended. ACAP recommends that in any child or adolescent who does not respond to one SSRI, that for either depression or anxiety, that they also have undergo thyroid screening. And then the American Association of Clinical Endocrinologists say that for every patient with depression, the thyroid dysfunction should be considered. They don't say lab screening, but at least doing a review of systems to see if the person has thyroid symptoms as well. So we know that basically there was this one really great study done in the European Journal of Endocrinology in 2014 that kind of looked at people with thyroid dysfunction, and we know that symptoms of hypothyroidism can be very vague, and lots of people with depression can have them even if they have normal thyroid function, or people can just feel fatigued for lots of reasons. So it's really looking at the number of hypothyroid symptoms that somebody has, and what they ended up doing was they saw that people with hypothyroidism had on average 5 real symptoms of hypothyroidism, and they recommended using people having 3 or more symptoms as a cutoff to get them thyroid screening. So this is where doing a review of systems for fatigue and dry skin and mood changes, constipation, hair loss, heavy or irregular periods can be very helpful. And most of the studies looking at when TSH is measured is done in the morning. So I've been telling my patients that, you don't have to get your TSH measured. You can get it measured at any time of the day, but because of the diurnal variations and the fluctuations just within a day of TSH levels and how all of the studies norming TSH are done during the morning, I've been telling patients that ideally, please just get it done in the morning if we're really serious about screening for TSH, if I'm really concerned about it. And then TSH can also just increase as people age, and then TSH and then the thyroid hormones have trimester norms within pregnancy. So if you have a pregnant patient, don't interpret by just the lab numbers. And then people who are morbidly obese can also have just a rise in TSH, but not necessarily have positive TPO antibodies. So there's controversy about what the upper limit for TSH is. And the idea is that if we lower it to, below 2.5, which we know that most people who have a normal thyroid function, their TSH is less than 2.5. But there are people who have a TSH above 2.5 to the 4 or 5 range that might have normal free T4, and those are people who are not technically considered abnormal. And the idea is that if we start screening and using 2.5 as a cutoff, we're going to be getting a lot more people on thyroid medication who maybe actually don't need it. And we know that some people, if they have an elevated TSH even, that within 2 years, just letting it go, that for a percentage of those people, that those symptoms will normalize. So our local lab here uses 4 as a cutoff. When I order TSH, I just look at the actual TSH number. I don't just look at H or L for high or low. And if somebody has lots of thyroid symptoms, they're treatment-resistant depression, and their TSH is above 2.5, I'm going to start thinking about how to think about thyroid a little bit more with that patient. So, and we know that patients who actually have hypothyroidism, who are taking Synthroid, we do want their TSH to be less than 2.5 and their free T4s to be within normal range. We know that people who have Hashimoto's, who are taking Synthroid, but whose TSHs are above 2.5 are much more likely to have depressive symptoms. So that's also a place that the psychiatrist can be looking for people to help and see if there's anything medically that might be contributing to why they're having such severe depression. And then one really good point too is that the conversion of T4 to T3 can be sluggish in a lot of people. So just because somebody has slightly elevated TSH but a normal T4, that doesn't mean that they're converting to the active T3 very well. And we often don't get labs to look at that conversion. But one of the things to look at is selenium as being really important in the conversion. Because selenium is really important to convert T4 to active T3. We know that there have been some studies that people with Hashimoto's who show that their thyroid tends to normalize and that they might report better subjective quality of life and well-being as well when supplemented with selenium to help there. And also going gluten-free for people with Hashimoto's. There have been some studies looking at people going on a gluten-free diet who have TPO antibodies, who's after a period of 6 months, whose TPO antibodies totally normalized for a percentage of those people after just going gluten-free. So thinking about points for intervention, just to conclude, so looking at thyroid for people who we're concerned, who have symptoms, and then making sure that the TSH is checked, that we are thinking about it, thinking about the conversion of T4 to T3 in patients with antibodies, using maybe selenium supplementation for a few months or recommending a gluten-free diet, working with a nutritionist can be helpful to normalize thyroid function for those types of patients, and to just be thinking about those medical contributions to why somebody is having such severe depressive symptoms. And that's it.